So it fits with the complication risk and the surgical risk going up. So how can we predict these patients? Okay, let's step to the clinical forum for just a minute, since the fellows and the residents and us see patients clinically. Is there anything at the time of diagnosis that can actually help me start to stratify my patient clinically into a high-risk group? So this was the group published in France, published in Gastro in 2006. The title was really about disabling Crohn's. Now in America, we've never used that title, disabling, right? Our patients are already calling us for parking passes, right? So the reality is we really try and limit the use disabling. So it's a French translation, so that's why it actually, I'm surprised the editors didn't ask to change the title. But what disabling to them meant, which is intuitive, you need immunomodulator, you needed surgery, you progress to more aggressive disease, develop complications, stricturing, penetrating disease. These were their clinical variables at diagnosis, which actually should send some kind of red flag to you to say your patient will progress to a more aggressive disease. Well, we've been talking about the fact that if you need steroids at diagnosis, your patient should be on immunomodulator forever, right? This has been an ongoing discussion whereby in Crohn's, not necessarily UC, but in Crohn's disease, if you have an individual who requires steroids up front, what we're saying and the teachings are is that patients should be on an immunomodulator, because your exit strategy of just staying on mesalamine for more complicated Crohn's disease is an unrealistic expectation that your patient's going to do fine after one course of prednisone if they've got deep ileocecal Crohn's disease. That's probably really an unrealistic expectation, as I say. So we've now shown over and over in multiple studies that you need to think about an exit strategy when you start steroids. Other things, we as pediatricians laugh, of course, because we think there is no difference between a 39-year-old and a 41-year-old in our ability to phenotype. But I can tell you there's a huge difference between a 9-year-old and a 39-year-old, right? So we have a new classification system that's going to be coming out that actually is going to be less than 16 and then less than 8, actually, based on a lot of this data that's come out. So in the Montreal classification, which is a phenotype classification, we're redoing it for pediatrics, and we've added A1A, which is less than 8 years of age. So there's going to be an even better way of phenotyping pediatrics. And no one will dispute that perianal disease at diagnosis is a bad prognostic indicator. And I don't think just a simple fistula. I'm talking complex, a complex fistulizing process. And I would even say, and I don't know if that's what you guys do, is that if you've got complex perianal disease, do most people agree that biologics should be the first line, right? I mean, there's no messing. To me, perianal is one of the most malignant forms of Crohn's disease, something that's complex. And therefore patients, to me, there's no negotiation. They can negotiate. I had a father, just to explain the LA culture, I have a father who is a transplant nephrologist who deals with all of these immunomodulators and immunosuppressives. His 9-year-old son has complex fistulizing disease, where he has now 3 cetons within like a 3-week period, 4 abscesses in posterior iliac, posterior fossa, anal fistulas and abscesses. And the father asked me if I can use low-dose naltrexone for his son, because he read about the lymphoma risk associated with TNF, and I said, sure, but a permanent ileostomy is probably not what your son wants, actually, so I'd say that maybe a biologic would be a more appropriate, and let's resume the discussion of low-dose naltrexone in a year, right? Let's table that for about a year. The reality is, I said, that this is the most aggressive, and in kids who get very complex perianal, they will lose their rectum. There is no doubt, and therefore we have to advance pretty quickly to a biologic, and even immunomodulators wasn't going to really, we don't have the 12 weeks. I mean, within a 3-week period, he now went to the OR 3 times. I mean, it just wasn't going to work. So we know that perianal disease is important. And remember perianal disease when I show you a little model that we've come up with in terms of predicting aggressive disease outcomes at the end of the talk. So what other variables can we think about? Well, endoscopic ulceration. Should the depth of the mucosal lesion, when we look in at our initial diagnosis, should we be using that to gauge how much healing we actually need to accomplish, and whether or not even waiting with immunomodulators is an appropriate time frame when you have someone with deep endoscopic ulcers. So I always think about, you look in and you're like, oh my goodness, if I just push that scope just a little bit, I may perforate, or whatever your mindset is. That's a patient that probably steroids is probably not going to be an appropriate intervention, and you should think about biologics. So there's increasing data and interest in depth of mucosal ulceration as being a predictor of when you should start to engage biologics, and steroids would be a negative association with outcome in this particular patient. And we are talking about, you know, those patients where you do historically small bowel follow-through, now evolving to MRE and CTEs, is that you see those big rose thorn ulcerations that we used to see on small bowel follow-through. That's not a patient should be on a corticosteroid. That's a patient who needs to be healed, because that patient is basically developing microperfs and is going to perforate potentially. And if indeed we believe the idea that steroids actually make things worse and inhibit healing, you may actually, so Dan Present may be right in a certain subset of patients that corticosteroids may actually worsen prognosis, and I'll show you some data to support that as well. So this was a study that was published in AJG that actually looked at the presence of severe endoscopic lesions, and again, not to get into severity, but you can also imagine that at DDW this year, there was so much stuff on mucosal healing and change in the activity index as a way of predicting outcomes at a year. So looking at, for example, in the Abbott trial Extend, which was the mucosal healing data, they looked at outcome at 12 weeks mucosally to predict the outcome at 54 weeks. Of course, complete mucosal healing was an unrealistic outcome and actually did not predict 54-week outcome, but we think that's too early to actually look for complete endoscopic healing. But a significant change in the score was very highly associated with outcomes. So endoscopic improvement is probably what we should be trying to achieve. And there's a lot of discussion now. Do we scope all our patients at 4 months, 5 months, 6 months after starting biologics? Should we be doing some kind of MRE, pre, post, some kind of way of measuring that we're actually approaching an outcome that we'd like to achieve? Because depth of endoscopic ulcerations actually led to colectomy in these patients who had severe deep colonic ulcers. So does the idea of looking at the endoscopic image actually help you choose which therapy you're going to use for your patient? And remember, none of these are in isolation. Even when I showed you the serologies, or if I show you any genetics, there's really not one thing. So the ideal thing to do, which Akbar, you can appreciate, is developing a risk model, right? Is to actually think about putting all the pieces together and developing the strongest model of risk to actually communicate to your patient that based on all of these variables, your risk score is A, mine is B, yours is C, etc., and be able to communicate why you feel that this actual pathway is the best therapeutic pathway to go to. And I can tell you, and I don't know if it's the same in adults, but our whole practice has changed regarding lymphoma, meaning all we do is counsel and provide psychotherapy for our patients who have actually been told they need biologics and are coming for a second, third, fourth discussion about the risk of lymphoma and infections, is particularly lymphoma in under 23-year-olds, for example. You know, that's the FDA did not do us a favor in August by putting up that it kills children and causes cancer. It wasn't really helpful for us who prescribe it regularly, so that's been a big struggle for us, is to try and appreciate and try and get the families to appreciate that the biggest risk to their child, for example, or any IBD patient, is the disease itself. Not the therapies that I'm giving you, but the actual disease itself. So, talk about serology. So I said endoscopic, maybe there are some clinical parameters, maybe some radiologic parameters that we'll be thinking about, and the next phase will be genetics. So we're right now running the entire genome against natural history, so we'll be able to share that with you probably, I guess, at DDW, or if not in a publication before, talking about how genes interact with natural history at a level of the whole genome as opposed to individual candidate genes, which is probably missing, you're missing something if you're just focused on already uncovered susceptibility genes. But we feel that serologies are one step further. Remember, I felt, or whether it's true or not, serologies are even further down the line towards clinical phenotype than the gene. There's so many things that modify genes, right? But it's felt that the serology is the actual